Welcome and thank you for attending tonight's webinar. The topic is COVID-19 and the impact of dentistry, April 8th, 2020. Featured speaker is Dr. Marie Fluent. You will receive 1 CE credit, which will be emailed tomorrow. If you have questions, please use the Q&A button located at the bottom of the screen. Dr. Fluent will address all questions at the end of her presentation. Dr. Fluent is a graduate of the University of Michigan School of Dentistry. Her dental career spans 35 years. Additionally, she has extensive experience and expertise as a dental infection control clinical instructor, educator, speaker, author, and consultant. She serves as education consultant for the Organization for Safety, Asepsis, and Prevention, OSAP. And for more information, you can check her out at mariefluent.com. Welcome, Dr. Fluent, and good luck.
Thank you. Thank you for the kind introduction, and thank you for your hospitality, especially to Michelle and Shauna for hosting this event and for the Michigan Dental Association. And as we all know, this is a very timely event, and dental personnel all over the country and the world are impacted by this, as we are in our personal lives as well. And we're very concerned. We're anxious to get back to business, and we want to assure that we and our loved ones and our patients are safe. So I'm hoping to address as much as I can. And as you know, this is an evolving situation, so I won't have all of the answers today. But where I do, I will share. And where I am not sure, or it has not been determined yet by CDC or World Health Organization, American Dental Association, or MDA, I will mention that as well. So bear with me if I don't have all of the answers today, because this is still evolving. Disclosures, I am a key opinion leader for Hugh Freedy, and I also consult for SciCan. Having said that, I'm not sharing any products with you today, so that there should be no impact whatsoever. I do want to share with you that the information that I provide in this webinar is not meant to be medical advice or legal advice, but rather information to mitigate the risk of transmission of coronavirus in the dental setting. And as I already mentioned, this information is changing by the day, sometimes by the hour. So for more up-to-date information about COVID-19, please visit the CDC website, World Health Organization website, American Dental Association, Michigan Dental Association, state and local health departments for the most up-to-date information. And being that all of us are pretty much at home these days, we're very well connected to our news sources. The course description, I want to share with, I will go ahead and read this, that as the COVID-19 epidemic unfolds, we in the dental profession in the United States have been called upon to suspend non-essential or elective dental procedures at this time. If dentists provide emergency or urgent care in their facility, it's imperative that they first consider the safety of the dental team and our patients. Our webinar will review the current state of the pandemic and evidence-based strategies to mitigate transmission in the dental setting and, of course, within the community. So today we will talk about the recent emerging infectious disease and up-to-date global status of COVID, the signs and symptoms of this disease, current recommendations for emergency and routine care in Michigan, prevention strategies that we personnel can take for the health and well-being of our dental team, and very importantly, I want to talk about reliable sources, references, and training resources regarding COVID-19 and all healthcare related information. With such an abundance of information going around, we're being bomb blasted day in and day out. How do you know what to trust? How do we know what's reliable? How do we know accurate sources? So at the end of the presentation, I'll go through some resources that are credible in areas that I would like to guide you. So first, let's talk about some terminology. An emerging infectious disease. The definition is a newly recognized disease that may occur in humans, newly appearing in different populations or a geographic area. It may be newly affecting many more individuals than it had once upon a time, it may have developed new attributes such as antibiotic resistance or a new strain of virulence. These diseases are unpredictable yet inevitable. And you can see that COVID-19 fits every one of these bullet points. Zoonotic diseases are diseases that originate from a non-human source and spread to animals, and COVID-19 is one such disease. And I'll share with you that in a couple slides coming up. A pandemic, as opposed to an epidemic, takes upon a wider or worldwide geographical area. There are a greater number of people involved than an epidemic. It often caused by a new virus or a strain of virus. Pandemics spread quickly from person to person, and there's generally greater mortality. And this creates social disruptions, economic loss, and general hardship. And you can see from COVID-19 and what we are all going through, this every bullet point in this description fits the description of a pandemic. We are in an all-out pandemic. Now, the last definition I want to share with you is something called community spread. Community spread refers to the spread of an illness where people who are infected in a specific area are not sure how they got infected. It cannot be pinpointed to a specific person, a specific time or event, but somehow they have come down with this illness. And that's pretty scary. And yes, we are seeing areas in the state of Michigan where we do have community spread. And I'll go through the geographic map in upcoming slides. But community spread is occurring with this illness. Now, here are some recent worldwide viral epidemics and pandemics according to CDC and World Health Organization. And you can see the first on the list is the HIV/AIDS. And by the way, this is nothing new. Viral epidemic and pandemics and viral and bacterial in nature have been going on since the beginning of time. But in our recent American history and worldwide history, the first on the list is HIV and AIDS, where we have over 32 million deaths. And then we had a SARS outbreak, a swine flu pandemic in 2009. 2012 up to now, we have the Middle Eastern respiratory syndrome coronavirus outbreak. And the mortality rate of that, the total death toll is 862. As of January. Ebola it has killed about 11,000 people in the United States. Fortunately, it did not impact us much. Zika virus has a death toll of about 53. And now here we are at COVID-19. And as of yesterday at 4 o'clock, we have 81,000 people, 865 who have passed away from this illness. And I do want to share that 3 of these on this list are coronaviruses. So a coronavirus is not brand new to us here and now. SARS is a coronavirus and MERS is a coronavirus. And you can see that the death toll was much less than what we are dealing with today. So let's talk about influenza versus COVID-19, because a lot of people have said to me, boy, isn't this just like the influenza virus? We have a lot of mortality, annual mortality according to with the flu. Isn't this the same? Well, let's look at the differences. First of all, on our list, you can see something called R naught. That little circle means naught, NOUGHT, and that stands for the number of people who will be infected by the average person with this disease. And you can see with influenza, that number is 1.3. That means the average person who is infected with influenza will pass that on to 1.3 other people. Now with COVID, the R naught is much higher, 2 to 2.5, and I suspect that number is underestimated because we have so many cases where of COVID-19 that are asymptomatic. So I'm suspecting that's a little bit lower. The incubation time of influenza is shorter than that of COVID, 1 to 4 days, as opposed to COVID-19, 2 to 14. The hospitalization rate is much higher for COVID-19, 2% compared to 19%. The case fatality rate is 0.1% or less, up to 1 to 3.4%, so much higher. The most important point on this slide is the immunity. With the influenza virus, all of us have some natural and hopefully acquired immunity. Natural immunity means once upon a time we had influenza and we have some immunological memory for this illness. Even if it is a different strain, chances are if we were reinfected with a new strain, our symptoms would be less than had we had no immunity whatsoever. And acquired is due to, of course, the influenza vaccination. But with COVID-19, there is no vaccination, and none of us have any immunity to it whatsoever. And that makes it pretty scary because it can spread through our communities much faster, and we are all susceptible. Now, this is pretty much a review. We all know and have read stories how it began. It is suspected that this disease originated from a bat and was transmitted to an intermediary animal, such as a pangolin. That hasn't been confirmed, hence you see the question mark on that slide. And then it crossed the animal to human barrier in a live market in Wuhan. They believe that happened sometime in December 2019. And at that point in Wuhan, there are millions of people and people traveling all over the world. And a microorganism can hop on an airplane alongside a passenger, and we're all connected with each other globally these days. And you can see just from the map and the news, it has spread literally like wildfire. So the situation summary, it was first identified in December 2019. By January 30th, the World Health Organization declared an outbreak, a public health emergency of international concern. By the end of January, Health and Human Services declared this is a public health emergency in the United States. By March, World Health Organization characterized this as a pandemic. By mid-March, March 16th, the American Dental Association called upon dentists to postpone elective procedures. And March 24th, the MDA supported the governor's executive order that mandated only essential services to the dental profession. And now we have all 50 states reporting cases, and all states have some sort of community spread that we already described. This slide comes to us from Johns Hopkins. It's an excellent slide that gives us an up-to-date count of the number of cases worldwide. And as of yesterday at 4 o'clock, we were at 1.4 million and 26,000 and some change. We've had experienced 81,000 deaths, but I like to focus on the right side of the screen where we focus on the number of people who have recovered from this disease, and we're at 300,000. And once again, I think that number is underestimated because, as I mentioned earlier, and will reiterate that we have a number of asymptomatic cases that are probably never even reported. So, but this gives us a good ballpark, and I think our public health colleagues at Johns Hopkins are doing an excellent job at keeping us posted and up to date on a daily basis. I don't like to see that curve on the lower right hand portion of the screen. You can see that our number of cases on a day-to-day basis is continuing to rise, and I have not seen flattening of the curve yet. So we all know what our parts are in flattening the curve, and hopefully we'll see that shortly. In the state of Michigan, here are the cases as of yesterday at 4 o'clock. And in Michigan, our total case count is 18,970, and we have about 845 deaths. And And from this slide, you can see there are hot pockets within the state of Michigan, and they pretty much are in the southeast portion of Michigan, Wayne County, Macomb County, Oakland County, and then we see some orange areas in the surrounding counties as well. And there are counties in the Upper Peninsula and the upper portion of the Lower Peninsula where we don't have any cases yet. However, once again, I question how much testing they are performing in those counties. So once again, it probably is a little bit underreported at this time. But that gives you an idea of what's happening around the state right now. So the clinical presentation of COVID-19 is this. First, there's an incubation period of 2 to 14 days. The average is 5 days. And that includes 25 days from the onset of the illness to discharge from a hospital, or if a person is going to die from this illness, it's generally 18 days from onset of the disease to death. The onset symptoms include fever, and as we've all read in the news or know by now, it's 100.4 degrees. That seems to be our magic mark we're looking for. The vast majority of patients who have symptoms report a fever, 83 to 98%. Then fatigue is a common symptom at onset as well, 83%. The infamous dry cough, 68%. And then some patients may have a productive cough as well, 33%. Shortness of breath, fatigue, and also sore throat and diarrhea may accompany the onset. There is a gradual onset of these symptoms, and some people have reported a loss of taste and smell as well. The average adult who gets COVID-19 is 59 years old, and a third to a half of people who have it have some type of underlying illness, and the median age for people who are critically ill are 66. And we're going to talk about that in a second, how those who have those at higher risk for severe illness. One statistic I would like to point out from this slide is my final bullet point that says up to 25% of those with disease remain asymptomatic. And this quote comes from Dr. Robert Redfield, who is the director of CDC. And that's pretty significant to us because if you are asymptomatic and still going to the grocery store and still heading to the pharmacy and maybe in the dental profession and not running a fever, we're putting ourselves at risk. So keep that in mind as well. This statistic will come back throughout my presentation. So the severity of symptoms of COVID-19, more than 80% have mild disease in which a person can recover. About 14% have severe disease causing breathlessness and pneumonia, and about 5% have critical disease, including septic shock, respiratory failure, and the failure of one or more organ, and then fatal disease is about 2%. And as I mentioned earlier, I've seen statistics range from 1.3 to 2.5, but we can average it out to the low 2%. Now, this slide shows severe outcomes among patients with coronavirus disease, and the three color codings on this slide, the light blue include the number of hospitalizations, the medium blue are those with intensive care unit admissions, and the dark blue represents the deaths. And what I want to point out from this slide is that the number of deaths increase with age. So the older you are, the more likely you are to have severe symptoms and die from this disease. But I also want to point out that the number of hospitalizations can occur in the young 20-something millennial generation as well. So when we looked at the news and saw spring breakers in Florida, basking in the beaches and being in very close contact with each other, I think, were misled that they're kind of immune to this disease and they cannot have serious illness from it. But you can see that as time has played out, that has been wrong. We're seeing younger and younger people who are in the hospital and on ventilators. And fortunately, younger people have a tendency to recover, older people and those who are medically compromised, not so much. So your risk profile of COVID-19, there is an elevated risk in places where you have community spread of the virus. Those of us in Southeast Michigan are at a higher risk than those of us in the tip of the Upper Peninsula. So it's dependent upon your location. Healthcare workers caring for patients with COVID-19 are at a higher risk. And I'm sure we've all seen the news of nurses and healthcare personnel who have come down with active illness and unfortunately and tragically have died taking care of these patients. People who are in close contact with COVID-19 patients, and maybe you have somebody in your home who has COVID-19, that puts you at a higher risk as well. Travelers returning from affected locations, and hopefully none of us are traveling right now anyway. Not at higher risk include infants and children. And if I didn't point that out on my previous slide, but you can see in the 0 to 19 age group, we have very few cases, no ICU admissions, and no deaths, fortunately. And it is not known if pregnant women have a greater risk or not. And this is referenced on the CDC website. They have a specific page for breastfeeding and pregnancy status. The case fatality info from COVID-19, people who have died from COVID-19, 0.9% of them had no underlying medical condition. So that means that reinforces those who are have a health status that they're pretty healthy and have no underlying medical conditions are at much less of a risk. Of those who died, 7% were diabetic, 10% had cardiovascular disease, 6% chronic respiratory disease, 6% had cancer, 6% had hypertension. And of those who were in ICU on ventilators and were experiencing respiratory failure, shock, or multiple organ dysfunction, 49% pass away. So the spread of COVID-19 includes close personal contact within 6 feet of an infected person. It's carried by droplets from the respiratory tract during coughing or sneezing. And the other point that I want to stress out is that there is an airborne route, aerosols. In the dental profession, we're very familiar with aerosols. We work with them with our high-speed handpieces. Our dental hygienists use ultrasonic scalers, and our ultrasonic unit for instrument processing also emits aerosols. So these have been very well studied in the dental profession, and I'll get into that in my next slide. Then there are contaminated surfaces or fomites. And I want to quote this New England Journal of Medicine article for you that really shows that contaminated surfaces have been, it has been proven that contaminated surfaces have transmitted infection. CDC says it is less likely that the most common route of transmission is droplets from the respiratory tract during coughs and sneezes. The virus is believed to survive 2 to 3 days on plastics and stainless steel, up to 24 hours on cardboard, and up to 3 hours in aerosols. And this is important because I'm sure we've all heard recommendations now. We all know that we have a shortage of personal protective equipment, and now it's been recommended that those of us out in public do wear a mask for our own protection if we have to go to the grocery store or a pharmacy or something of the sort. In those situations, it has been recommended that we store our one and only mask in a paper bag. And that is because the virus lives less long on cardboard and paper type surfaces than it does in plastic. And that would be the reason why. And of course, there is documented community spread. And as I mentioned earlier, the spread may occur before people become symptomatic or people who are asymptomatic. It's not thought to be the main way the virus spreads, but I believe it is happening. And CDC believes it's happening. This slide shows droplet and airborne spread of infection. The large infectious droplets, and not to be gross, but if somebody coughs and hacks and a particle is flying out of their nose, those generally are transmitted 1 to 3 feet away. Smaller little infectious droplets are carried 3 to 5 feet away, and you can see from this 1 to 3 and 3 to 5 feet stage, that's why CDC came up with the 6-foot perimeter between people, the distance that we should be keeping between people. It's thought that these particles and droplets would be settled and we'd have at least 1 foot of leeway. But look how far infectious droplet nuclei or aerosols can be transmitted, 5 to 160 plus feet. And if you think about that, think about in dentistry. You spray Lysol in the air, you come back into the operatory, about 15 minutes later, you can still smell a lingering in the air. If you enter a room at home and a woman has a very strong perfume and you come back in the room 10 minutes later and there's a hint of it in the air, those are droplet nuclei or aerosols that you are indeed smelling. And that lets you know how long they do linger in the air and to what distance. So that's what we're dealing with in the dental profession when we talk about our high-speed handpieces and our ultrasonic scaling units and the emission of aerosols during those procedures. We'll talk about that more in just a minute. So the CDC has come up with guidance, interim infection prevention and control guidance for dental settings during COVID-19, and this first came out on March 16, 2020. I'm going to go through the key components and key takeaways on the next slide, but I also want to stress to you that they updated this interim guidance today at 4 o'clock. So yours truly here was updating her slides today at 4 o'clock for you. So some of my points may be redundant in subsequent slides. So please bear with me. It feels like information is evolving at the speed of light and I can barely keep up. So hang in there with me. So from the interim guidance that was publicized on March 16, here are the key takeaway points. First of all, we need to minimize our chance for exposure in the dental profession. And we do that by only scheduling emergency patients. Ideally, we should be pre-screening and our patients, communicating with them ahead of time. Now is the time to implement teledentistry and really listen to what their symptoms are on the phone to see if it is truly an emergency that requires treatment today, here and now, or is this something that can wait? So we're trying to minimize our chance for exposure no matter what. Number 2, adhere to standard and transmission-based precautions. Up to this point, we have hammered into dental personnel standard precautions, and that include, and we know this like the back of our hand. All of you are wonderful at standard precautions, including the wearing of gloves, the wearing of other personal protective equipment, treatment of our environmental surfaces, having an infection prevention program, and sterilization of our dental instruments according to CDC guidelines, respiratory protection program. Those are all components of standard precautions. But now we've expanded that and we have something called transmission-based precautions, and I'll elaborate on what transmission-based precautions mean in a couple more slides. So stay tuned. I'll touch base on that in just a moment. Patient placement, and we're supposed to have patients separated from each other and from us. Face masks for any patient who might have any type of respiratory symptom right off the bat. If they have acute symptoms, they should be referred to a medical center and not seen in our setting whatsoever. Number 4, take precautions when performing aerosol generating procedures for COVID patients, and this should be conducted in an AAIR room. I'm sorry, AIR room, and that means air airborne infection isolation room. Most of us don't have that. I'll elaborate on that in upcoming slides. We can also help with collection and diagnosis of respiratory specimens. CDC says we can do that. I don't know anybody who's got a testing kit or a way to do that yet, but this is on the CDC website. Number 6, manage visitor access. In other words, keep all visitors and accompanying people out of the office. Implement engineering controls, and that would be barriers to protect the receptionist, floor markers every 6 feet apart, as we've seen in the grocery store these days. Those are some examples of engineering controls. Monitoring and managing ill and exposed healthcare personnel. If you have a healthcare personnel who does have respiratory symptoms, he or she should be asked not to come into the office without any consequences for not reporting to work ill. Training and education of healthcare personnel, especially with regard to COVID-19 and the transmission of airborne illnesses. Environmental infection control, we'll review that momentarily. Establishing reporting in between healthcare systems and looking for additional recommendations from CDC, ADA, Michigan Dental Association, and OSAP, which is the Organization for Safety of Sepsis and Prevention. Now, here are some updates, and notice my little red pictogram on the right side of the slide that says hot off the press. This is the information that was updated today at 4 o'clock. So this, the interim guidance that I just shared with you on the previous slide is still in effect, but CDC would like to add this morsel of information on this slide and my next slide. So in addition to what I already discussed, CDC would like us to make sure that dental personnel understand the risk posed to them during treatment of COVID patients. We should be screening dental personnel at the beginning of our shift for fever and any type of respiratory symptoms. If they are symptomatic, they should have put on a face mask immediately and leave the workplace. Exclude personnel who might be at higher risk for severe COVID-19 illness. And this is new for us. I've had many questions from dental personnel saying, boy, I'm taking Humira for whatever. I'm just finishing up chemotherapy and I have X number of to go. I'm immunocompromised for whatever. On this CDC website, there is a page for exclusions for dental personnel who might be at higher risk for severe disease. And on that list also includes patients with moderate to severe asthma, those who are 65 years old or older, and those who are immunocompromised for one reason or another. I invite you all to look at that website. I have the link on the bottom of this slide. And if you just want to Google in CDC interim guidance for dental personnel, all of this information will be available to you and at your hands. Number 2, recommendations for contacting patients prior to emergency dental care. And this is where our teledentistry comes in. It's recommended that the dentist communicates with the patient to determine if it truly is an emergency, and then go through those screening questions. And I have those upcoming on a couple more slides, so stay tuned. Number 3, recommendations for providing emergency care to non-COVID patients and patients who have completed their home isolation clearance. What does that mean? Patients who have been staying at home and patients who have not been in contact with anybody else in their household and are completely asymptomatic. And there's a precise definition on this interim guidance website who fits into those categories. Patients who are not have completed home isolation are considered to be COVID-free, and it is okay to see those patients for emergency dental care at this time. However, if you see those patients, it is we should be avoiding aerosol generating procedures when possible. Of course, I don't know how you perform modern dentistry without a high-speed handpiece, but as much as possible, use hand instrumentation and absolutely no ultrasonic scaling for my dental hygienists. Avoid dental handpieces and the air water syringes when possible. Use ultrasonic scalers, not recommended. Use four-handed dentistry and high evacuation system and rubber dams when possible. Then there is possible exposure guidance. That means if you saw a patient and you believed that they were free of COVID, and yet 2 days later they came down with a fever and other COVID type symptoms, now what do you do? And there is guidance on the CDC website on what you do then and who you need to contact. Then there is a contingency and crisis plan. What do we do when we don't have PPE available to us and we do have a patient who has severe emergency situations that need to be taken care of? So I invite you all to look at that page, and that will be updated periodically, but the newest update occurred today, like I said, at 4 o'clock. So, part 2 of the interim guidance that is hot off the press. Number 1 says use the highest level of personal protective equipment available. And that includes gloves, gown, eye protection, not personal eyewear, not personal eyeglasses, but actual goggles that are meant for healthcare professionals that have side shields and full coverage. And we are asked to use an N95 or higher. Disposable respirators or an N95 mask, if we use it, we're supposed to remove it and discard it after a single use. Clean and disinfect reusable eyewear in between patient encounters. Change our gown if it becomes soiled, and discard disposable gown, and cloth gowns should be laundered after each use. If a respirator is not available, use the combination of a surgical mask, that would be our level 1, 2, or 3 mask, ideally a level 3 mask, and a full face shield. I'll get into that in just a moment. Discard the mask after exiting the operatory and change the mask if it becomes wet. If minimally acceptable combination of personal protective equipment is not available, do not perform emergency dental care. Refer to somebody, one of your colleagues who does have that available, or a hospital setting. Strict adherence to hand hygiene, cleaning and disinfecting the room and equipment according to CDC guidelines, and I'll get into that in just a moment. So that's the brand new information from CDC. Now I said I was going to get back with you and talk about these transmission-based precautions. What does that mean? Well, our standard precautions that we've been taught to address here in the dental setting include droplet precautions and contact precautions, and we know what's required to prevent disease transmission by those routes. We perform hand hygiene, we wear personal protective equipment such as our surgical mask and our gown and protective eyewear, but what's different with transmission-based precautions is now we are dealing with airborne precautions due to those aerosols that I shared with you a few slides ago. To protect ourselves and against airborne illnesses, we must put on a fit-tested N95 or higher level respirator before room entry, and remove the respirator after exiting the room and closing the door, and the door to the room may remain closed. Well, if we look at that and we think about our offices, most of our dental practices do not have an airborne infection isolation room or a single patient room. Most of us have an open concept design, and many of my orthodontic colleagues even have bays where many patients sit in the same area, just separated by a small little partition, if any. Most of us do not have a respiratory protection program, and most of us do not routinely stock N95 respirators. So we have an issue here. So now we talked about what CDC has to say, and let's talk about OSHA, what OSHA has to say. OSHA says that there are different occupational risks, and looking at this pyramid, we can say that there are very high exposure risks for healthcare personnel, including doctors, nurses, dentists, and that includes my dental hygienists and assistants too, paramedics, emergency medical technicians. This is because we are well within that 6-foot perimeter of our patients, very, very close to their mouths and respiratory secretions when we perform dentistry. So we are at high risk. OSHA goes on to say that to protect workers at very high risk, we need to implement engineering controls. That means appropriate air handling systems. COVID patients should be placed in an airborne infection isolation room if available. Use isolation rooms when performing aerosol generating procedures on patients with known or suspected COVID-19. And once again, most of us don't have that available to us. Administrative controls, policies to reduce exposure. Yes, we can develop policies. Yes, we can post signs requesting patients to report their symptoms of respiratory illnesses. And yes, we can use disposable face masks. We can provide workers with job-specific education and training, and we can ensure psychological and behavioral support is needed if necessary. And PPE, those who work closely or in contact with 6 feet of COVID-19 patients should wear respirators. So once again, we might not be able to perform safe care at this time, and if not, screen and refer for care. And this is why we've been all asked to defer routine care at this time. Now let's get into CDC guidelines. Where you see the summary for infection prevention practices in dental healthcare settings, basic expectations for safe care. This is a summary of our basic expectations for routine care prior to COVID-19. These are things that we already have implemented in our office, and I will give a quick review right now. Number one, we're supposed to have an infection prevention program, and it needs to be a written program, and we all know that. We all know that we need supplies necessary for standard precautions. We all know that we are supposed to have somebody in charge of our infection control and health program, such as an infection control coordinator. We all know that this is supposed to be written, and we all know that we are supposed to have a system for early detection and management of potentially infectious persons at the point of entry of our facilities. And this is stuff we've already been doing. Now, and since COVID-19 has come about, we're supposed to cancel non-critical procedures according to CDC and ADA, reduce the number of dental personnel involved, streamline it. We don't need a front desk personnel in the office and a dental assistant and somebody to sterilize our instruments. We need to streamline our personnel to limit exposure. We need to exclude more susceptible workers. We already talked about that. Maximize any separation conditions. Set up most protective supplies. That means have all of our PPE up and ready to go if we were to see an emergency patient. We don't want to be hustling through the office digging for this and that. And plan for transmission-based precautions. As we concentrate on emergency care, this will free up our PPE burden for the frontline healthcare workers, and it will allow us to care for our emergency patients while alleviating the burden on our hospital emergency departments. So here are our screening questions when we consider teledentistry or any type of remote modality for screening. We want to ask our patients, boy, do you have any respiratory symptoms and what might that be? And have you traveled in the last 14 days? And if so, where? Once again, we're considering areas that have community spread. Have you been in close contact or have you been caring for a patient with COVID-19? And if the patient has responses to travel or close contact and symptoms, absolutely do not see them. Contact the local or state health department and have the patient contact the healthcare provider. Boy, where do you get this number for the local and state health department. At the end of this webinar, I have made a complete list of resources for you. And on that list, there is a list of all state health departments in the United States. And you can go and find Michigan, and it will give you your local department as well. So use that as a resource. So ADA guidance says that if we have an emergency or emergency treatment is necessary, we should work with medical providers to determine if what appropriate precautions need to be taken on a case-by-case basis, and determine whether your facility is appropriate and consider referral. And we've already gone over that, but I just wanted to reiterate that the ADA and CDC are in alignment with each other. So now we're back to key recommendations for respiratory hygiene and cough etiquette. And once again, these are measures that are already in place for our facilities before COVID-19. We should already have signs at the entrance of our facility and encouraging our patients and visitors to cover their mouth and nose when they cough or sneeze, use and dispose of tissues, perform hand hygiene after hands have been in contact with respiratory secretions, provide tissues and no-touch receptacles in our reception room or our waiting room, provide alcohol hand sanitizers or a place to wash their hands, offer masks to coughing patients or symptomatic patients, provide space and encourage patients who are symptomatic and asymptomatic to sit as far away from each other as possible, and educate personnel on the importance of infection prevention measures to prevent spread of respiratory pathogens. But we've already been doing all of the above, and there are a couple more morsels of information now. Now they're recommending to have patients immediately perform hand hygiene upon entry of the facility using an alcohol-based hand sanitizer. Now, there's been information running around the dental community on pre-procedural mouth rinses. CDC stands by its infection control guidelines from the 2003 document that says no scientific evidence indicates that pre-procedural mouth rinsing prevents clinical infections, but studies show that pre-procedural rinse with an antimicrobial product can reduce the level of oral microorganisms and aerosols and spatters during procedures. And even with COVID, they stand by that recommendation. However, there was a paper that came out in the International Journal of Oral Medicine. I have the link below for you that says chlorhexidine may not be effective to kill COVID-19. And this was before it was labeled COVID-19. It was called 2019 novel coronavirus. But now the name has been changed. And it goes on to say that since the coronavirus is vulnerable to oxidation, pre-procedural rinses containing 1% hydrogen peroxide or 0.2 povidone is recommended. And that is the active ingredient in like Listerine. So now, according to this article, hydrogen peroxide and Listerine are effective. CDC maintains that it can't hurt. But no studies really prove that it does prevent disease transmission. So you're going to see more and more of this information. I'm seeing it the more I read recommendations for treating patients with COVID-19, and this is where this information comes from. There are specific posters that can be displayed in reception rooms about the importance of covering your cough, especially for COVID patients. These particular posters are available free of charge and are available on the CDC website. If you Google in CDC posters for COVID-19, these will come up. Feel free to copy. There's no copyright on them. They want you to copy them and use them in your facility. When it comes to hand hygiene, here are our key recommendations. Once again, this is what we've always been doing. We perform hand hygiene when our hands are visibly soiled, after barehanded touching of any contaminated instruments, equipment, materials, before and after each patient, before we put our gloves on, immediately after glove removal. We use soap and water when our hands are visibly soiled, and otherwise an alcohol-based hand rub may be used. used. But I want to share with you a couple morsels of information with regard to COVID, and that is that the actual virus itself is easily destroyed with either hand washing or alcohol-based hand rub. The outer coating is a lipid or a fatty type of layer that's easily dissolved, and the alcohol hand rub must be 60% alcohol or higher. Ethyl alcohol is much better than isopropyl alcohol. Isopropyl alcohol is the alcohol that you would get like from a pharmacy that's used that you would purchase for any household type of need. But ethyl alcohol is what is in our alcohol-based hand sanitizer and is what is recommended. Now I'm seeing more and more people saying, gosh, I can make my own hand rub. It's scarce to find, difficult to find in grocery stores, etc. I can just use X, Y, and Z. Well, that might be fine for home use, but do not make your own hand rubs for clinical use. You should be using products that have been manufactured for healthcare professionals. Now, key recommendations for personal protective equipment, and these are measures that already we should be taking before COVID-19. We should have our personnel educated on when and where to use PPE, gloves whenever there's potential for contact with blood or bodily fluids, non-intact skin or contaminated equipment or devices. Never wear the same pair of gloves for more than one patient. Don't wash our gloves. Perform hand hygiene immediately after glove removal. Wear protective clothing that covers our skin and personal clothing. Most of us wear scrubs in the office setting. Wear mouth, nose, and eye protection during procedures that are likely to generate splashes or spray, and remove our PPE when leaving the work area. Now, CDC guidelines for face masks during the prevention of COVID-19. Masks are recommended for people with COVID symptoms, healthcare workers, people taking care of somebody with respiratory diseases, and those who are well in the public to wear surgical masks to prevent themselves from any respiratory disease. And that's new. In the last couple of days, CDC came out with that recommendation that we should all be wearing masks when we head out in public and to minimize heading out anyway. Respirators should be prioritized for those on the front line of healthcare right now. Surgical face masks, this is my slide. This is my pet peeve when wearing face masks with the loop-de-loop around the ears. Make sure you don't do that. You can see that that leaves a gap in the side of the cheek. You want a tight seal around the perimeter as much as possible. Masks should be changed between patients or if they become wet or soiled, and not all masks are created equally. This slide shows the mask levels that we've been wearing in dentistry, and typically we wear the 3 categories on the left: low barrier, moderate barrier, or high barrier. And these are also ASTM level 1, 2, or 3. On the right-hand side of the slide, we have N95 masks, and I want to point out that these masks are typically used when treating patients with airborne diseases such as tuberculosis or influenza, and now COVID-19 fits into that category. Look at the filtration capabilities on the bottom portion of this slide. You can see a low barrier mask provides no filtration efficiency whatsoever. A moderate barrier or ASTM level 2 will filter bacteria up to 98%. A high barrier will filter 98% of bacteria, not viruses, and particles up to 0.1 micron. And the size of the COVID virus itself is about 0.125 microns. An N95 will block 99.9% of very small particles, 0.1 micron test particles. But for that to be effective, we need a tight fit, a tight seal. We'll get into that in just a second. And you can see right now we should be using a level 3 at least with a face shield, and ideally an N95. So the ADA guidance for this COVID crisis says that N95 with a positive seal and a full face shield should be worn when treating patients in close proximity to the respiratory system, similar to the protocol for medical teams performing intubations. If N95 masks are not available, surgical FDA-approved masks must be worn for each patient and not reused in conjunction with proper utilization of goggles, gowns, and gloves. So I'm going to go back one slide again, and I want to stress that this high barrier mask, ASTM level 3, with a face shield would be the minimal protection that ADA recommends. Ideally, we should be wearing N95. Now, you've seen people heading off to Lowe's and Home Depot to buy N95 respirators for industry. Will they work? Let's talk about the differences. Ideally, they should form a tight seal over the mouth and nose. If you purchase one over the counter from Lowe's or Home Depot, we don't know if it's going to provide a tight seal or not. Hopefully you purchased one in the right size, but you have not had a fit test or a seal test on this. Fit testing, if you're in general industry, if you are working in industry, you would be required to have a fit test. If you purchase it from Home Depot, not so much. The N95 respirators for healthcare are certified by NIOSH. The fluid resistance is the main point that I want to point out on this slide. N95 respirators for healthcare are fluid resistant, whereas those that are manufactured for industry are generally not. That's our main difference here, the fluid resistance. In addition, the respirators for healthcare are Class 2 medical devices. So if you purchase one from Home Depot and that's what you've got, that's at this time, it's a good option, but wear this full face shield that I have imaged on the right-hand side of the screen in addition to that to give you fluid protection. Now, there are many people selling counterfeit N95 masks. Be careful. Many counterfeits are out there, and if you go to Amazon.com, you can see many of them are available. You want to see that NIOSH in black letters. You want to make sure that it has got a TC approval number. They will have a model number stamped, a lot number stamped, and the filter designation with the NIOSH series after that. So look for all of those labels and markers, and if they're not there, chances are it's counterfeit. We don't know if it's going to provide the protection that you need, and we don't know if there are harsh chemicals in there that you might be breathing in. So be careful. Obviously, their face masks are in short of supply, and CDC has a strategy for optimizing the supply of face masks. And contingency capacity means that we're providing care without a change in practice. There are, that was conventional. Then there are contingency, crisis capacity, and no masks available. And that's when you see people making their own at home, and that is absolutely not acceptable for the healthcare setting, especially in dentistry, where we are face to face with aerosols. So it might be okay out in public, but I cannot guarantee the filtration efficacy of a fabric designed face mask out in public. We just don't know. Not safe, don't do it. So environmental infection prevention practices, we need policies and procedures for routine cleaning and disinfection of all of our areas within the office. And now that's becoming even more important to wipe down the frequently touched surfaces. Clean and disinfect surfaces that are not barrier protected, use an EPA registered disinfectant with a label claim, and follow those instructions for use. So clean and disinfect your fomites. Those are contaminated surfaces such as door handles, knobs, chairs, desks frequently. And they're saying also to alternate treatment rooms to allow airborne pathogens to settle in between. And that's what our dental schools are doing at this time. I communicated with the University of Michigan School of Dentistry and UDM to talk about how they are taking care of emergency patients at this time. They're closing the door and letting the dust settle for several hours before they go ahead and seat the next patient. Now, this slide shows that we can, some There are different levels of disinfectants, high level, intermediate level, and low level. In the dental setting in the United States, we use intermediate level disinfectants, and they are designed to kill all the microorganisms that are listed and all of those that are below. And you can see on this list that coronavirus is at the very bottom of the list. It is very easily killed. All of our environmental surface disinfectants are very susceptible to killing this virus. But having said that, there is a lot of controversy going around on whether or not your disinfectant is appropriate for killing SARS-CoV-2, which is the virus that causes COVID-19. So there is an EPA List N for disinfectants that are effective against this emerging pathogen. And once again, I have that available to you in the handout of resources at the end of this lecture. Follow your label directions and always clean before you disinfect your surfaces. Looking ahead, are we going to be asked to implement a respiratory protection program? I don't know, hence the question mark on the right-hand side of the screen. The goal of a respiratory protection program is to prevent the transmission of aerosol transmitted diseases such as measles, chickenpox, tuberculosis, and now COVID-19. This program needs to be a written program. Once again, you need to have somebody in charge of it. There need to be policies and procedures about evaluating your hazards. How do you select your respirators? Medical evaluation of people who are to wear the respirators. And there's a whole list of criteria that they need to fit. For instance, respirators may not be appropriate for people who have pulmonary diseases, people who might be claustrophobic, etc. So there's a list of a questionnaire that medical personnel need to evaluate all respirator wearers before they go through the fit testing. Then there's a fit testing protocol and a seal testing to make sure that that is snug around the perimeter of your mouth, nose area. Also, I need to stress that an N95 mask is not appropriate for men with beards or facial hair. On your handout, you'll see there's one slide that I want to share with you from CDC that shows a description of all kinds of beard configurations and what's appropriate and what's not for wearing the effective wearing of an N95 mask. The training, proper use, storage, maintenance, and repair and disposal, then program evaluation, and of course, you know OSHA, there's always the record keeping component. Are we going to be asked to implement this? I do not know at this time. It hasn't been mentioned. If we were going to implement a brand new program such as this, number one, we need to have supplies available. And as you know, we are very short on PPE. And number two, it's going to take a long time to implement this. So looking ahead, this might be a possibility. I can't say for sure. Don't panic. It's not on the horizon now. Also, I'm getting lots of questions about air filtration devices, purification systems, HEPA filters. Do these work? I've been in contact with the Division of Oral Health from CDC, and they said, well, if you implement any of these, consider them an adjunct to your respiratory protection program, not instead of. But be careful, there's lots of false claims out there, and I really want you to discern if this is a product that's going to be beneficial to you or not. Companies are recognizing the need and the panic among dental personnel and healthcare professionals, and really providing, in some cases, false promises. So really discern if this is an appropriate product for you. Number one, you need to make sure that whatever device you purchase can accommodate the size of your operatory. Calculate the cubic feet in your operatory. Once again, we need to make sure that we have a closed door, or if you have an open operatory design, you need to make sure that this device can accommodate your entire office. Also look at your current HVAC system. How many air exchanges per hour may it offer? And the air exchanges per hour in dentistry, we would be asked to provide 12 exchanges per hour. In hospital emergence operating rooms, they typically have 15 exchanges per hour. I'm a little over the hour, but bear with me. I just have a couple of slides to go, and then I'll get to Q&A. While your office is closed, there are different things that you can do to keep productive. Review your infection control program, your hazard communication program, HIPAA policies. I would start educating yourselves on respiratory protection programs, just so that if CDC does make a recommendation, you're not blindsided. Just be thinking about that in the back of your mind. You can always participate in CE, communicate with your patients, and implement a teledentistry program. Update your website, deep clean your offices. While you're doing that, get rid of all of those magazines and toys from your lobby. Follow the manufacturer's instructions from your dental equipment so you know what to do during closure. And you might want to consider your sterilizer, your dental unit water lines, your amalgam separators, compressors, vacuum systems, and also remain informed of evidence-based recommendations that might modify your infection control protocol as needed. When you look for reliable sources regarding COVID-19, look for sites that rely on experts who use well-accepted scientific analysis, reputable medical or dental journals, have a mission to inform and protect the public, such as CDC, World Health Organization, ADA, MDA. Look for sites that are not promoting or selling a product. Consider Medline Plus from U.S. National Library of Medicine, CDC, major university and medical centers, major news outlets that have deep expertise in health reporting, such as New York Times, Washington Post, and the Boston Globe's Stat News, also Wall Street Journal as well. Be careful of what you read online, especially social media. It may or may not be an accurate source of information. Really discern. For further education and training, here are some recommendations for you. And I want to point out on the right-hand side of the slide, OSAP, Organization for Safety, Asepsis, and Prevention. Since the COVID outbreak has occurred, OSAP has opened its website to everybody, and they have a wonderful toolkit available for you with lots of references for you. Also, keep in touch with the Michigan Dental Association, ADA, NIOSH, CDC, World Health Organization. All of these sites will provide reputable information for you. Now, I want to close with, I have two slides for you with quotes. First is Anthony Fauci, MD, who is the director of NIH, National Institute of Allergy and Infectious Diseases at NIH. And he says that COVID-19 outbreak is a stark reminder of the ongoing challenge of emerging and re-emerging infectious pathogens and the need for constant surveillance, prompt diagnosis, robust research to understand the basic biology of new organisms and our susceptibilities to them, as well as to develop effective countermeasures. That's a big, long quote, but what it means is that this is upon us. We need to provide surveillance. We need to be on top of our game. We need to diagnose quickly. We need to get our research going and hopefully develop vaccinations ASAP. And a quote from the home front. This is from my husband, Tom Fluent, who has been a psychiatrist for 30 whatever years, and now is involved in hospital administration. But in his years in the military, active duty military, and from psychiatry and treatment of children, he says, never underestimate the resilience of the human spirit. And it gets me choked up as I think about it, because number one, it's from the home front, and number two, it does give us an element of hope that we will get through this, we will get over it. There is an end on the other end of this, and we will be resilient and once again develop a new sense of normalcy. So on that happy note, okay, I'm 5 minutes over, not that bad in the grand scheme of things, considering the quantity of material. Shauna, did you want to say any housekeeping measures, or should I just head into Q&A at this time?
You can head directly into Q&A, Dr. Fluent.
Okay, great. I'll head right into Q&A. I will have these resources available for you. Shauna will make sure that you all get them at the end. And I'm going to do the best I can with Q&A, and here we go. Okay, first of all, obviously the most important issue is the health of our team members, patients, and our families. After the financial impact is of most concern. And I heed you. I'm not in practice anymore, and I can't even imagine the stress and strain on all of you who are practice owners at this time. I understand at the moment, if we are approved for a loan, we must take the funds within 10 days of approval. And you know what? I can't answer that question for you. This came from Dave. And Dave, I remember you from dental school. How are you? That would be an MDA question. I know they have lots of resources for HR and financial considerations, legal considerations, and I'm going to pass you over to MDA for that. I can help you out with infection control, but anything HR or financial, I'm not your go-to girl. If our employees are getting unemployment, oh, here we are once again. This is a financial and office-related question. Can't help you out there. I'm sorry. Here's another question that says, if testing is mostly being done on patients who meet particular criteria, how can it be said that 25 patients of COVID would be asymptomatic when those patients even be tested? And yes, you are right. And this is a question from Emily. I won't share your last name, but you are correct. And that's why I pointed out to you that 25%, up to 25% of those who are infected are asymptomatic. And it doesn't make, if we're performing a screening and taking temperatures, people are going to fall through that crack. So we can't really depend on temperature taking. I'm hoping that there will be an accurate screening mechanism where we can see if a person does have antibodies to the coronavirus, or if they are indeed infected, and that would be a more reliable measure, but we're not at that point yet. So you are correct. We are in a conundrum. How long does the virus stay on clothes? And this comes from Charles. And this is a good question, and I don't know the answer to it. I do know that it can stay on cardboard up to, 24 hours. And on clothing, we don't have precise recommendations from CDC at this time. But in the interim guidelines, they do say that we should keep our lab coats, our contaminated lab coats, separate from our other laundry. And if we go by OSHA guidelines, we should be sending our laundry into a laundry facility that handles it separately and off-site, or have a laundry facility in our own general practices. But most of us aren't doing that. Most of us are taking our contaminated PPE home to wash, meaning our gowns. If you do that, especially in the days of COVID, make sure that you launder it separately from your household laundry. And I saw an article from AMA today, the American Medical Association today, that said crank up that dryer. Dry on a high heat, and that will kill the virus. The virus is very susceptible to killing. So I hope that helps answer your question there. How much, this is a question from Daniel. How much more likely are immunocompromised patients, such as people going through chemo, to be hospitalized and die from COVID-19? I can say, Daniel, from the beginning of this lecture, I said that the death rate for people with cancer was 6%. So that, and Shauna, correct me if I'm wrong. Are these slides going to be available to our attendees? I know you're muted right now, but if you can hear me.
They can, if you'd like for that to happen, we can definitely send those.
Okay. Daniel, I will make my slides available to you, but I want to let you all know that these slides are outdated as quickly as they're made, because the guidelines and recommendations and the science behind COVID-19 changes so rapidly that this will be quickly outdated. I will provide a slide deck for Shauna, who will send it to you, and it will give you those exact statistics earlier on in my presentation, but please be aware that this information will be quickly dated. Okay, here's a question from Andrea. It has been said that acquiring the virus through aerosols leads to being exposed to a larger viral load, which can be worse prognosis for the person acquiring it. Is this true? Well, for infections to be transmitted from one person to another, it's going to take, like, as you mentioned, a little bit of more of a viral load. In other words, if you breathe in one virus particle, are you going to get infected? Um, uh, Probably not. How many viral particles is it going to take to be infected? The answer to that question is determines the virulence of the disease, how quickly you can get the disease. And if you're blasted through aerosols in a dental setting, that means you're exposed to a greater quantity of viruses as opposed to the supermarket where you might be breathing in somebody's cough or sneeze that has a couple of viral particles in the air that might be 150 feet away from you. So if you're acquiring viruses through viral load through aerosolization in the dental setting, yeah, you're going to be exposed to many, many more than somebody who is far away from you. So it depends on how many the quantity of viral particles that you actually inhale. But as far as the prognosis depends on the risk factors of the person who is susceptible. And once again, the elderly, the immunocompromised, those with underlying pulmonary diseases, etc. So those are the determining factors there. I hope that helps. Here's a question from Crystal. Is Lysol something that we should be using to disinfect the air after aerosolization occurs? I don't know. I don't know the answer to that. The answer to that question is not within the CDC recommendations, nor within OSHA regulations, nor any of our regulatory documents. I don't know the claim on a Lysol product itself. I don't know. Can't help you out there. Sorry about that. The next question comes from Michael. Thoughts on an isolite versus a rubber dam? A rubber dam is an actual physical barrier, whereas an isolite is it's a retraction and a suction mechanism, and the suction component of an isolite is more like a saliva ejector as opposed to an HVE. So if I had to compare the two, I think we're comparing apples to oranges, but a rubber dam would be more effective at eliminating aerosols in the air during aerosol generating procedures. Richard, if you need to exclude an employee who may be at high risk due to underlying concerns, what are our legal potential legal issues and risks with this? That's a legal question. I can't help you out there. Sorry about that. But you are correct, excluding an employee who might be at risk due to underlying concerns. And I urge you to look at the CDC website and the areas of patient dental personnel who would be at high risk and should be excluded. Jeanette, so if the patient has continued to work, should you not see them at all for emergencies? If the patient has continued to work. I hope I'm understanding this correctly. I'm assuming, Jeanette, you mean that if you're seeing a patient for care and this patient continues to work outside their home, in other words, somebody who's going out into public and is exposed to other people. Well, would be a person who would not be considered quarantined. And Jeanette, I'm going to refer you to the CDC interim guidance page where they give an exact description on what a person, who falls into that category. And because that information came out so recently, i.e. 4 o'clock today, I don't have that on the top of my head, and I apologize. Dave, I understand the need for enhanced PPE, but it is unlikely that we will have access to this quantity of supplies, and it is not practical to defer care until we meet these requirements. And David, you're right. I understand that. And I don't know what the answer is at this time, and I'm hoping that our supply chain meets the demand in the very near future, that our companies are stepping up to the manufacturing needs. I'm hoping that our curve slows down so that we have fewer patients who are hospitalized, and we'll free up some PPE for us. But you are right. There's absolutely a conundrum right now. The supply does not meet the demand, and it is very unlikely that we're going to have this access if doors should open in a few weeks. So you're right. There is a conundrum. Richard, if your office is not able to place doors or other typical barriers, what do you suggest to isolate a room, hanging drop clothes like we often see in grocery stores between cold areas and general floor space to create a door? Once again, those drop cloths are not really, we don't know the filtration capabilities of the cloth that you might be hanging there, so I don't know the answer to that. There are so many unanswered questions with regard to this disease and what we need to do to protect ourselves and to go ahead and continue providing care to our patients. I can't help you out there. I don't know the answer to that, and I don't know what the solution might be either. So stay tuned. Question from Shadows: are there handouts? The handouts would include, yes, I will make my PowerPoint available for you in a PDF, and I will provide for you the list of resources. Constance, how do we fit an N95 mask? Is there somebody who can do this for us? And there is something called a fit test kit, and that those are generally available, and it's something that you would bring into your office, and it shows it shows how tight the seal is around the perimeter of your face, and there's like a little cage, if you will, looks like a PAR type of mask that you breathe in and out of, and it shows how tight the seal might be and if the size is accurate for you. Unfortunately, Constance, there are no fit test kits available now at all. So there is a conundrum there as well. If we're all to implement a respiratory protection program, that's a big component of the program, and we can't implement that because we cannot ensure an accurate fit at this time. So stay tuned. Once again, I'm hoping the supply meets the demand in the near future. Richard, should we use a hang drop cloth or equivalent at the reception desk between business staff and entering or exiting patients? I can't comment on that, but I can say grocery stores are putting a glass barrier between the cashier and the customer, and so we're seeing more and more of that out in public. And the CDC now is recommending that front desk personnel are wearing a mask when they for any type of settings where you would have a patient care at this time. So I think we're going to see more and more receptionists being required to wear personal protective equipment even at the front desk. So once again, this is still evolving, and that's one of the questions that I will share. I'm in contact with CDC, Division of Oral Health, and I am sharing with them anytime I give a webinar, what are some of my frequently asked questions, and I'm submitting them right on over to Division of Oral Health. And I'm happy to announce that when they came out with their new interim guidance today, it did incorporate a lot of my frequently asked questions that I gave to them a week ago. So I will pass this along, and if I hear anything, I'll let you know. And Richard, you have, I just want to say to you too, Richard, My email address is on the very first slide of this presentation. Feel free to email me and I can help out and keep you abreast of any new information that comes along my way. Um, we are asked to see emergency patients to help the hospitals. Many of us are general dentists and have never used N95 masks or higher. Now we are asked to not see patients if we do not have appropriate PPE. We can't obtain these. How do we see patients in need? Donald, you are in a conundrum, and I can't agree with you more. As I've reiterated, please, I'm going to pass this along to CDC, and I'm hoping our supply meets our demand. Cafe wipes effective to kill COVID-19 on hard surfaces? Yes, absolutely. They are on that EPA list of disinfectants, and you can check that for yourself. I've made that available to you in your resources. Look under Environmental Protection Agency, the list, and that list is provided. Since we don't have a fitted N95 mask in most cases and we need to use high speed for most dental procedures, are we not able to see regular patients until a solution can be found? As many as COVID-19 patients are not symptomatic after emergency care is lifted in the future. You are correct. Once that we are allowed to return to care, we are still going to have many patients out in the public who may be asymptomatic or pre-symptomatic, and you are correct. We don't have a good solution at this time, and this is one of the areas where I don't have an answer for you. Sal, do you see the possibility of dental offices being required to test on the spot for COVID-19 to definitively rule out positives? That would be awesome. I would love to be able to see a quick and rapid test that can be done before a patient is even admitted into the facility, so we can care for them safely and provide safe care for our dental team members as well. In an ideal world, that would be awesome. I'm hoping that we have some people who are involved in high tech and are developing such a rapid screening test right now. So stay tuned. I'm hoping technology catches up as well. Shouldn't every N95 mask be fit tested? Years ago that was done? Yes. Yes, it was. All of us should have a fit test before we start wearing them, and the fit test should be performed annually thereafter, and that's part of an OSHA respiratory protection program, and you are indeed correct. But as I mentioned, Eric, we don't have the fit testing capabilities at this time, and right now, as our medical colleagues are flying by the seat of their pants, literally. Where do you go for the fit test? It's something that you order, and I'm hoping that in the future, when these do become available, that a number of offices can bundle up together and have one and have all of their employees fit for it if we are required to have a respiratory protection program. Matthew, how do you wear loops with a face shield? Matthew, there are face shields that can accommodate loops underneath, and you have to find one that has a thicker layer of foam that goes over the forehead that can accommodate the distance and the length of the loops underneath it. Yeah, keep looking, check with your colleagues, and I think you'll come across one. And if you don't, contact me and I can help you out. Here's a question. Are K95 masks effective? A K95 mask is the Chinese equivalent, that is their rating system of an N95 mask. In an ideal world, we would be wearing N95 masks exclusively. Right now, if that's what you've got available to you, go ahead and use it. Next question from Kathleen. How about using a double level 2 mask and a shield if there aren't any N95 masks? Doubling up your mask levels, I don't think is going to, it's not really recommended. And I have seen some people wear an N95 mask and put a surgical mask on top. CDC says that that's not a great idea for several reasons. One, it'll make it a little bit more difficult to breathe through that. N95 masks are already difficult to breathe through. And if you add a surgical mask on top of that, it makes it extra hard to breathe. And as that happens, you can build up more perspiration, more secretions, and make that mask wet. And once a mask becomes wet, it's no longer effective. So not a good idea. Doubling up a level 2 mask, I have never heard of that. I think a level 2 mask and a shield I've never heard of doubling up, but for sure the highest level you've got and a face shield is your best bet. Email the slides. Yes, we will get you the slides, Charles. Mary, this is a question about a specific brand of air purification system, and I cannot comment on that. I don't know these systems inside, outside, and backward, what they're capable of, what their FDA clearance might be. I can't comment on that. You'd have to contact the manufacturer themselves and see what they claim their product does, and then look at your facility and determine if it's appropriate to use in your facility. Do you have a closed door? Do you have an HVAC system that already turns over X number of air exchanges per hour? So there's a lot of complexities to your question, and you would have to contact the manufacturer of that device and do some more investigative work. Okay, I've got time for just about 2 more questions. You mentioned the current recommendation for an employee who might be on Humira. My assistant is on this biologic, and I am seeing emergency patients if absolutely necessary. The current recommendation for her helping me at this time. Sorry, Jack, she should not be helping you at this time. I'm hoping you can find a different assistant, somebody else who can help you out. Ideally, you should have an assistant by your side so you can perform four-handed dentistry with high evacuation. But your assistant should not be exposed to this at this time. So with that, let's see. I cannot get through all of the questions at this time. Let me answer one more, and then I will pass the microphone back over to Shauna. A quick question from Melissa. When can we plan to go back to doing elective work if we have so many patients that need the next step for ortho, crown seating, etc.? Melissa, I can't answer that yet. I think we can go back when the governor says we can all go back on public, and the CDC and American Dental Association and Michigan Dental Association say that it is safe to resume elective care at this time. And I don't have the answer to that. I wish I did. But I do know that when we do go back to work, it's not going to be business as usual. It's probably going to be a gradual increase into our new normal, a new comfort zone for our patients, and maybe new protocols and policies that are in place. So don't plan on turning the light switch and having life go back to normal in X amount of time. It's going to be a gradual approach. We're not there yet. So with that, I am going to turn the microphone back over to Shauna. And Shauna, if you want to tie up any housekeeping measures, and then I will work on putting these slides in a PDF and getting them to Shauna, and as well as the list of resources for you. Shauna?
Thank you so much, Dr. Fluent, for all your valuable information. For everyone who's still on the line, we do have over 120 some questions that need to be answered. We will get all those questions answered. Please just give us a day or two. We do know what your question is, and we do know who asked it, so we'll get those taken care of. If you asked a question that doesn't involve Dr. Fluent's expertise, such as an HR question or a surgically clean air question, we will also point those to the right direction, and we'll have those departments get in touch with you regarding your questions as well. Again, CE vouchers will be emailed within the next day or two, as well as answers to these questions Dr. Fluent's handouts, and everything else we promised you we would get to you, we will definitely have to you within the next day or two. Again, thank you for staying on the webinar, and hope you'll join the next one, which is going to be held on April 23rd. Check your email. Thanks again, Dr. Fluent.
Thank you, Shauna, and have a good night, everybody. Thank you for spending this evening with us.